Good morning. The subcommittee will come to order. Thank you all for joining us today as we begin to discuss 6 legislative proposals aimed at strengthening the health care and services we provide to our honored veterans through the Department of Veteran Affairs. The 6 bills on our agenda this morning are draft legislation, the Veterans Integrated Mental Health Care Act of 2013, draft legislation, the Demanding Accountability for Veterans Act of 2013, H.R. 241, the Veterans Timely Access to Health Care Act, H.R. 288, the CHAMP VA Children's Protection Act of 2013, H.R. 984, to direct the Department of Defense to establish a task force on Eurotrauma, and H.R. 1284, to provide for coverage under VA's beneficiary travel program for certain disabled veterans for travel for certain special disabilities rehab. These bills seek to address a number of important issues facing our veterans. I expect today's hearing to encompass a highly detailed and thorough discussion of the potential merits, challenges, and implication of each proposal before us. I look forward to working with the ranking member, the bill sponsors, and other subcommittee colleagues to fully evaluate these proposals and ensure that we advance meaningful and appropriate legislation to fulfill the promise we made to our veterans. My bill, the Demanding Accountability for Veterans Act, is intended to address the pervasive lack of action taken by VA based on their own agreed-upon timelines for remediation of issues and recommendations included in VA Inspector General reports. Currently, the IG tracks open recommendations on their website and in their semi-annual report to Congress, the latest of which show that there were 177 total open reports and 1,140 total open recommendations. Of those, 33 reports and 93 recommendations had remained open for more than 1 year. My bill would require the IG to make a determination whether VA is making significant progress on implementing VA's own agreed-upon action plan and timeline to implement the recommendations made by the IG in a report concerning public health or patient safety. Under the bill, if the IG determines that significant progress has not been made, the IG would be required to notify the committees and the Secretary of the Department's failure to respond appropriately. Following notification, the Secretary will be given 15 days to submit the names of each VA manager responsible for taking action to the IG. In turn, the Secretary would be required to promptly notify each responsible manager of the issue requiring action, direct that manager to resolve the issue, and provide him or her with appropriate counseling and a mitigation plan. The Secretary would also be required to include in the responsible manager's performance review an evaluation of actions in response to a relevant IG report and prohibit the individual from receiving a bonus or other performance award for failure to take action. The goal of this legislation is simple: to create a culture within VA where problems that go unresolved are unacceptable. Far too often, I've seen serious issues that the IG has identified go unaddressed by the department. Such inaction is intolerable where the care and services provided to our veterans is concerned, and is well past time for those at VA who are responsible for implementing needed changes to be held accountable for their work. I am hopeful that the Demanding Accountability for Veterans Act is the first step in ensuring that they are. I'll be happy to answer questions my colleagues may have on the bill and listen to the views of all of our witnesses. To that end, I'd like to thank all the sponsors for taking the time to speak with us about their proposals today. I am grateful for each for their leadership and advocacy efforts on behalf of our veterans and their families. I would also like to thank our Veteran Service Organization partners and other stakeholders, both those who will testify here this morning and those who admitted statements for the record for their valuable input. I'm also grateful to the VA for being here to provide the department's views on these important proposals. With that, I now yield to Ranking Member Brownlee for any opening statement she may have.
Thank you, Mr. Chairman, and thank you, excuse me, for providing a full schedule today that includes 6 bills before us that address some of the unique needs of our nation's honored veterans population. The bills pertain to a variety of areas that affect the lives of veterans every day, and this subcommittee has conducted many oversight hearings to understand the problems and then to fix them. The 2 bills on today's agenda, including one of your proposals, Mr. Chairman, are pieces of draft legislation to address mental health concerns and increasing accountability at the VA. The next bill, H.R. 241, the Veterans Timely Access to Health Care Act, was introduced by Mr. Ross of Florida and pertains to timely, organized, and scheduled visits to VA medical facilities. H.R. 288, the CHAMP VA Children's Protection Act of 2013, sponsored by Mr. Michaud, ranking member of the full committee, would amend the maximum age for children to obtain medical care under CHAMP VA from 23 to 26 and effectively reflect the Patient Protection and Affordable Care Act enacted in 2010. And I will speak further on this bill during the first panel. Next, H.R. 984, introduced by Mr. Guthrie of Kentucky, would direct the Secretary of Defense to establish a national task force on Eurotrauma. And finally, my bill, H.R. 1284, the Veterans Medical Access Act, would provide better access for blind and severely disabled veterans who need to travel long distances to obtain care at a special rehabilitation center. Oftentimes, blind and catastrophically disabled veterans choose not to travel to VA medical centers for care because they cannot afford the cost associated with that travel. Currently, the VA is required to cover the cost of transportation for veterans requiring medical care for service-connected injuries. H.R. 1284 would extend those travel benefits to a veteran with vision impairment, a veteran with spinal cord injury or disorder, or a veteran with double or multiple amputations whose travel is in connection with care provided through a special disabilities rehabilitation program of the VA. Our disabled veterans have already made the greatest of sacrifices, and I firmly believe, as I'm sure everyone here in this committee hearing today believes, that no veteran should be denied needed medical care. I thank all of the members for their thoughtful legislation, and I want to thank you, Mr. Chairman, for including my bill here today. Thank you, and I yield back my time.
Thank you, Ms. Brownlee. I would now like to welcome our first panel to the witness table. At the dais, we have our chairman, a well-respected and well-established leader for our veterans, to discuss his draft legislation, the Veterans Integrated Mental Health Care Act of 2013. We also have my friends and colleagues, Dennis Ross, representative of Florida's 15th Congressional District, and Brent Guthrie, representative of Kentucky's 2nd Congressional District. Brent is also a West Point grad and a veteran of the Army's 101st Airborne Division. I'd like to thank him for his service and uniform. Thank you all for being here this morning. It's a pleasure having you, and I'll yield this time for the chairman for his testimony.
Thank you very much, Mr. Chairman. It's great to be with you here today, all the members of the subcommittee on health, representatives from the other VSOs that have joined us, and other interested stakeholders and audience members, and I appreciate the opportunity to discuss my draft bill, the Veterans Integrated Mental Health Care Act of 2013. 2 weeks ago, yesterday, I spent the day in Atlanta with many members of the Georgia delegation to discuss inpatient and contract mental health program mismanagement issues at the Atlanta Department of Veterans Affairs Medical Center. This visit occurred after the VA Inspector General issued 2 reports which found that failures in management leadership, oversight, and care coordination at the Atlanta VAMC contributed to the suicide deaths of 2 veteran patients and the overdose deaths of 2 others. Now, alarmingly, the IG found that approximately 4,000 to 5,000 veteran patients fell through the cracks and were lost in the system after the Atlanta VAMC failed to adequately coordinate or monitor the care they received under VA's contracts with community mental health providers. I wish that I could say that the issues in Atlanta are an isolated aberration. Unfortunately, that would be far from the truth. Rather, the Atlanta story is just the latest in a tragic series of incidents highlighting serious and systematic deficiencies plaguing the provision of mental health care to at-risk veterans through the VA healthcare system. Now, since 2007, VA's mental health care programs, their budget, and their staff have increased significantly. Yet the numbers of veterans taking their own lives has remained stagnant for the past 12 years, with 18 to 22 veteran suicide deaths per day since 1999, according to VA's own records. I could go on, but the bottom line of this is the one-size-fits-all path to mental health care that the department is on is failing the veterans most in need of its services. And the time to act is now. I have been and will certainly continue to be a strong and supported advocate of VA taking action to hire staff and to address the continued failures of mental health care provided within its own walls. However, it has become abundantly clear through the data that I have discussed this morning, through committee oversight in this room, through numerous IG and Government Accountability Office reports, and through the personal accounts of the veteran constituents that call my office and the offices of my colleagues on a daily basis to ask for help, that VA cannot cope with the magnitude of mental health needs our veterans experience in a bureaucratic vacuum with the normal VA business as usual approach. In order to truly maximize mental health care access for today's veterans, VA has got to embrace an approach to care delivery that treats veterans where and how they want to be treated, not just how VA wants to do the treatment. Some have said this could undermine VA health care as we know it, and nothing could be further from the truth. This isn't about supplanting the VA healthcare system, it's about supporting that very system. To truly address and resolve the breakdown in the provision of mental health care services to veteran patients, VA has got to adopt an integrated, coordinated care delivery model for mental health care. Most importantly, VA has got to adopt a mental health care delivery model that is truly veteran-centric, one that meets and cares for veteran patients where they are, treats the entirety of their concerns with supportive and timely wraparound services, and recognizes and respects their unique circumstances, goals, and healthcare needs throughout their lives as a veteran. That's why I've proposed the draft Veterans Integrated Mental Health Care Bill that's before us this morning. It would take the first important step to help veterans in need, whether those services are provided in or outside of VA facilities. Specifically, the draft would require VA to provide mental health care to an eligible veteran who reflects or elects to receive such care at a non-VA facility through a care coordination contract and with a qualified entity, and require such entity to meet specific performance metrics regarding the quality and timeliness of care and exchange relevant clinical information with the VA. It would ensure that existing mental health care resources, both those found within the VA facilities and those provided to veterans through fee-basis care, were managed effectively. It would also ensure that the care provided to veteran patients in need of mental health services is timely and that it's convenient and coordinated from the initial point of contact throughout the recovery process. I understand that some veteran service organizations have expressed concern about waiting until VA rolls out its own new contract care initiatives. And while I appreciate and I understand and respect those views, I look forward to working closely with them to address those concerns but the time for waiting is over. Last year, the IG found that more than half of the veterans who go to VA seeking mental health care services wait 50 days on average to receive an initial evaluation. This year, the IG found that thousands of Georgia veterans had fallen through giant cracks in the system and may or may not have received the care that they so desperately needed. We cannot wait to see what next year brings. When a veteran is in need of mental health care services, the difference of a day or a week or a month can be the difference between life or death, contentment or continued struggle. The time to act is now. I look forward to working hand in hand with committee members, our VSO partners, and other stakeholders to strengthen the language in this draft bill and address any issues that may be raised during the subcommittee's discussion this morning. I appreciate you holding this hearing, Mr. Chairman, and for your hard work and steadfast leadership of the Subcommittee on Health. I yield back.
Thank you, Mr. Chairman. I look forward to hearing from the VSOs about your legislation, and it certainly is timely. With that, I will yield to Mr. Ross, my colleague. Thank you.
Thank you, Mr. Chairman. Thank you, Ranking Member Brownlee and committee, for allowing me to testify on behalf of legislation I have introduced entitled the Veterans Timely Access to Health Care Act. Americans, veterans are the backbone of the freedom and prosperity this country has enjoyed for over 200 years. We owe them a debt that we can never truly repay. Unfortunately, across the country and across Florida's 15th Congressional District, veterans continue to encounter unacceptable problems and delays receiving appointments from the Veterans Administration for essential medical and specialty health care needs. For instance, the VA has set a goal to provide an initial medical health examination within 14 days from the time a veteran contacts a VA medical provider to schedule a consultation. The VA claims to have met this goal with a 95% success rate. However, an Inspector General report in 2012 published greatly contradicts these claims. In fact, the IG report determined that the VA met its goal only 49% of its time. As Chairman Miller pointed out, for example, more than 184,000 veterans waited approximately 50 days to receive critical mental health evaluations, not treatment, just a formal evaluation. This is a disgrace to our veterans and something that should not be tolerated. Additionally, Chairman Mike Kaufman of the Subcommittee on Oversight and Investigations held a hearing on March 14, 2013, to examine patient wait times at VA medical facilities. Sadly, the chairman revealed that according to VA documents, at least 2 veterans died last year from diseases while waiting for a medical consultation at the VA. That is why I'm proud to have introduced H.R. 241, the Veterans Timely Access to Health Care Act. This legislation, supported by the Military Officers Association of America and the Retired Enlisted Association, will ensure that veterans seeking primary and specialty care from a VA medical facility receive an appointment within 30 days, period. This legislation also contains a number of detailed reporting requirements so that Congress may better track the VA's progress. And if the VA discovers they are not meeting their goals and the mandated 30-day access to care, it is my hope that they will reach out to Congress before their reports are filed so that we can work together to meet the needs of our nation's brave and courageous veterans. We are all on the same team here, with the same goal of providing timely, high-quality health care to our veterans. However, this legislation will go a long way in ensuring veterans' critical needs, like those needs of the more than 184,000 veterans who waited over 50 days for initial mental health screening. We want to make sure they no longer slip through the cracks. It will also prevent the unnecessary loss of life of those veterans in need of medical care and consultation. Moving forward, I would like to work with this subcommittee to strengthen this legislation, potentially including additional access to care standards. Today, this legislation is a first step to hold the VA accountable. Thank you, Mr. Chairman, and I yield back the balance of my time.
Thank you, Representative Ross. I appreciate your words. Brett, why don't you just go ahead with your testimony as well?
Thank you, Mr. Chairman, and good morning, Ranking Member Brownlee and colleagues. I come before you today as both a member of Congress and a former Army officer to thank you for your past support of this issue and continued work that we need to move forward. As you may know, genitourinary trauma, or simply urotrauma, is a class of wounds that literally hits below the belt. Urotrauma accounts for wounds to the kidneys, reproductive organs, and urinary tract organs. These injuries are some of the most common and debilitating suffered by our veterans from IED detonations and have long-lasting physical and psychological impacts. Urotrauma is one of the signature wounds of the IED and now accounts for 1/8 of all injuries suffered by our troops in Afghanistan. Unfortunately, the most recent data available suggests that this figure is still rising, even after nearly doubling in incidents between 2009 and 2010. I know we're in the Veterans Committee today, but by way of background, let me paraphrase Department of Defense report to Congress titled Genital Urinary Trauma in the Military, and the Army Surgeon General's report entitled Dismounted Complex Blast Injury. According to these papers, urotrauma on today's battlefield exceeds incident rates of all prior conflicts by at least 350%. And yet, the DoD, under Secretary for Personnel and Readiness, concedes that urotrauma injury is not part of the standards of pre-deployment training for U.S. military surgeons and nurses. And that existing infrastructure for tracking these casualties is not sufficient to assess the long-term prognosis of GU trauma injuries. This lack of adequate infrastructure is exacerbated by the inherent complications of transitional care from DoD to VA, where most victims will receive treatment for the remainder of their lives. Now, let me say that this is not my view that the VA or DoD are ignoring urotrauma. To the contrary, I believe that many skilled professionals are hard at work on the issue. But as is often the case in government, their efforts are divided, unintegrated, and because of this, less effective. By my tally, there are 6 government agencies currently working on urotrauma, and while I'm heartened that this research is occurring, I'm discouraged that there seems to be little dialogue or centralization of information. Put simply, we aren't learning from experience, and if we are, we're learning too slowly. And that's why I introduced H.R. 984, a bill that I have authored with help of practicing urologists who have cared for wounded warriors in Iraq and Afghanistan. This bill would unite public and private resources to address the growing problem that is urotrauma. I'd like to highlight 2 specific opportunities for improved care that are within the committee's jurisdiction. First, the existing infrastructure to track urotrauma patients is not sufficient. We need the research infrastructure to facilitate urotrauma outcomes research and corresponding follow-up with DoD, and most critically, after transition to the VA. Unfortunately, one thing I have heard time and again is that the Joint Theater Trauma Registry, which tracks approximately 16,000 trauma victims, lacks the specificity of detail needed to accomplish this end. VA, DoD, and healthcare providers need a better platform to coordinate care across a lifetime for our wounded warriors. Related to this is a second issue I'd like to focus on, transition of care. Rather than mincing words, I will quote the American Urologists Association Urotrauma Task Force directly. It is clear to those urologists in DoD who care for our soldiers with complex urotrauma that the transition to the VA is currently fraught with barriers. These barriers include deficits of communication of the detailed medical and surgical history of injured service members from DoD physicians to VA physicians. Another problem continues to be GU injured soldiers within the VA system being cared for in locations where access to expertise in GU trauma is lacking. One solution to this problem would be to designate care coordinators to urotrauma victims. These coordinators would need access to DoD and VA health information and guide our wounded warriors toward existing centers of excellence in polytrauma care. However, as a member of Congress, I'm not wedded to a single solution to this or any other improvement to urotrauma care. That is why 984 allows for a big tent solution. As DoD has said in writing, we need inter-service and inter-agency relationships to facilitate aggressive, innovative, and relevant translational, and outcomes-based clinical research. And that's what this does. It brings together VA, DoD, HHS, Surgeon Generals of all of our armed services, and civilian expertise to create a plan to care for our wounded warriors from the point of injury to their final resting place decades from now. Urge this committee to continue the work it has already done to further our care for these wounded warriors and suffering from these effects, and I yield back my time.
Thank you very much, Representative Guthrie. I'll now yield again to the ranking minority member, Ms. Brownlee, to speak on H.R. 288.
Thank you, Mr. Chairman. H.R. 288, the CHAMP VA Children's Protection Act of 2013, was introduced by Mr. Michaud, ranking member of the full committee. Thank you for including it in today's agenda. Dating back to 1973, the CHAMP VA program was established to provide health care services to dependents and survivors of certain veterans. It is designed to provide care in a manner similar to that of DoD's TRICARE program, in that it is a fee-for-service program that provides reimbursement for medical care provided by the private sector. Individuals who are eligible for CHAMP VA are the dependents of certain living and deceased veterans who were rated permanently and totally disabled for a service-connected disability, died from a service-connected disability, or died while on active duty, which was not due to personal misconduct. As we are all aware, the Patient Protection and Affordable Care Act requires health plans and health insurance issuers that offer dependent coverage to extend this coverage until the adult child turns 26 years of age. The fiscal year 2011 National Defense Authorization Act provided DoD with the authority to extend TRICARE coverage to age 26 as well. However, this provision has yet to apply to CHAMP VA. H.R. 288 would extend that same coverage to CHAMP VA beneficiaries. It is a simple fix that it would ensure that our veterans' families are able to receive health care commensurate with the rest of the nation. And I thank you, Mr. Chair, and I yield back the balance of my time.
Thank you, Ms. Brownlee. I think I'm going to yield myself 5 minutes for a few questions concerning the legislation, and maybe you all can answer a couple of points that I have. Mr. Ross, thanks for your interest in ensuring that our veterans have timely access to care. And as you know, care delayed is care denied. Some concerns have been raised about H.R. 241 that would establish in law a single measure of timeliness. I'm looking forward to the opportunity to work with you on this legislation to achieve your goal, which I think is to ensure that veterans have a clear expectation that they will receive timely care and that the VA will be held accountable. But there's some concern I have about one standard. There's different types of issues that come up, like, for example, the mental health time issue may be different than a routine appointment. So can you respond to these questions that I came up with when I read your legislation?
Thank you, Chairman. I think, and I agree with you. I think, we're trying to impose one standard of 30 days when the VA says that they now do it within 14 days. We know they don't meet that standard. What we're trying to do is assess the situation. We know we have a problem. We're trying to get to the solution. And by putting in initially a 30-day maximum period of time by which the appointment must be given, and then having the assessment thereafter of a report from the Secretary that's due to Congress that would show how many appointments were really made within 30 days, how many in excess of 30, how many in excess of 6 months. From that data, we should be able to then decide what is the appropriate standard for appointments. But I use this legislation as a step, the first step in trying to recognize that we have a problem in providing adequate and necessary health care in an expeditious fashion. And so while I'm not seeking that 30 days should be the standard, it's a starting point to assess where the problems are and then hopefully take corrective action based on the information we get back from the Secretary.
All right, okay. Is there any enforcement mechanism about this in this? Is it just the beginning, you're saying that later on?
Chairman, sadly, there's not any enforcement. I say sadly because in most of these regulatory issues, we have little enforcement ability with the agencies that we deal with. And I think that one of the things I would really enjoy working with this committee is trying to find an enforcement mechanism. I think once we identify what the solution should be in terms of the appropriate access to care standard, depending on the diagnosis, or for that matter, just the initial evaluation, then I think we can look at what the enforcement should be for their failure to do so. I mean, for something that would be, like a physical soft tissue injury, there may not be as great of enforcement penalties if it was something more of a severe mental health condition or something that requires exigent medical care and treatment at the time.
Thank you.
Thank you.
Mr. Guthrie, I'm excited that you brought this up here because, I'm a trauma surgeon myself, and I got to meet with some of the great urologists that provide urotrauma care, and I just want to commend your efforts to get this thing going here. I know that this bill would unite public and private resources to address the growing problem in urotrauma. What's being done in that area to, make the private and public sector work together there?
Well, one of the great examples of that is that one of the people who brought this to my attention is a physician who you're going to hear from in the second panel, who's in private practice, but was deployed forward with the National Guard, so experienced it firsthand and sees it back now, back home in country. And so what we're hoping to do, what I'm not saying is the DOD and VA aren't dealing with this. As I mentioned in my testimony, they're dealing with it through several different categories. And what we're trying to do is unite it. So we do have private research with public research. I think one example that sort of fits, it's just that in Boston, in the Marathon Blast, I think the trauma surgeons there had been trained with some Israeli surgeons, and it just happened that they had that special training at that time and undoubtedly saved lives. And so what can happen through the military and bringing in private sources together can be replicated to help people, not just military folks, but that's what the focus is, try to bring everybody together from both sides, whether you're DOD employed or you're in private practice or private research.
Well, I know that it's going to be a challenge for our veterans who want to go home, and yet in their hometown or their local VA may not have an expert urologist trained in urotrauma, and that a task force to address that issue, I think, is a great idea, and coordinating care nationally to get the best taking care of this.
That's what it seems to kind of respond from the biggest thing that I think can come out of this is actually that, because our guys have gotten really good, unfortunately, at training because they see it in Landstuhl and here. But when our soldiers go home to live out the rest of their lives, I think that's what is so important for this committee to focus on. They're not going to be in Walter Reed or in Landstuhl for the rest of their lives. They're going to be home, and that's what we need to focus on. Thanks
Great.
for that comment.
I'll yield now to the ranking member, Ms. Browley, if she has any questions.
I don't have any questions at this time. Thank you.
Mr. Wenstrup? Ms. Custer?
Thank you, Mr. Chairman, and thank you for convening this hearing. I think these are critical issues for us to be dealing with, and I commend you and Ms. Brownlee for your leadership on this, and thank you to our colleagues. Both of these issues, I think, are critical, and I just want to lend my support. I don't have any particular questions. You've been very informative, and the testimony is very helpful, but I just want to say that we appreciate you coming forward. Thank you for your service, and please know that on both sides of the aisle here on the Veterans Committee, these are bipartisan, nonpartisan issues that we want to work with you on and work with the VA and the VSOs and make sure that our troops get the care that they need. And I'm particularly reading the testimony, the confluence of the mental health issues with the complex trauma issues, I think is the lesson, sadly, that we'll all learn from the last 12 years, is that from what I hear back in my district in New Hampshire, the impact, the cumulative impact on the family structure, and I think about the Eurotrauma issues, and I think about more women getting into the military and seeing combat, and what the long-term implication is for that, for our society. So I just commend you, and I'd like to work with you and work with the chair and the ranking member on this committee and just say that I think it's really significant work that we're doing. Thank you. I yield back the balance of my time.
Thank you, Ms. Kuster. Mr. Hilskamp, do you have any questions for the panel?
Yeah, thank you, Mr. Chairman. I appreciate my colleagues for bringing these proposed bills before the committee. I had a couple questions and wanted to see what your thoughts were. particularly first for Congressman Ross. Recently, the committee reviewed a report from the OIG about, I think it was entitled Reported Outpatient Wait Times, and what was disturbing to me was some evidence that certain facilities either had a unusual definition of what the wait time was or actually potentially falsified the data. And I found that very concerning, especially when we talk about the need, and I agree with you, to set a standard by which they'll reach. But when we found cases, or the OIG found cases where they went in on the day they actually had their appointment, went in and says, okay, that was the wait time, the day they came in rather than the time they applied. Any thoughts on that and response from, you'd think, from the Department of Veterans Affairs when we have these kind of things occurring?
Thank you, Mr. Holzkamp. Every specialty, medical specialty, has practice protocols by which there's a recommended course of treatment and rehabilitation depending on the diagnosis. And while not having a single standard is going to work for in terms of getting into to see the healthcare provider that they seek, I think what's important is that we make sure that we collect the data appropriately as to when the first request is made until their first evaluation, and then subsequent follow-ups can also be offered. But I think that what we're trying to do is recognize that we have a problem here, and I think that a lot of it has been covered up, and the issue is a lot worse than what we know it to be. So again, I would ask to work with this committee so that we can have some enforcement mechanisms in there to not only hold the Veterans Administration accountable, but also to make sure that those that are collecting the data are doing it appropriately and accurately.
I appreciate that. I think that's absolutely essential, and particularly for your legislation or ways to hold the VA accountable, particularly for those that it aims to serve. And Brett, comment for you, or a question. I serve a very rural district. I'm sure you understand that. And, I was actually visiting with a veteran who was in Syracuse, Kansas, and this was about a year ago, and he had noted where he was instructed by the VA to make I think it was a 261-mile one-way trip, and he made the round trip 3 times in 10 days. And he said, Congressman, the care they wanted me to get, and it wasn't urology, it was another type of care, I could have got that in my local hospital, and the VA wouldn't allow that to happen. And by the way, just 5 days ago, the local hospital announced they could be shutting their doors. And one issue I've had is, well, how can we make certain that whether on the care that you mentioned, the care Congressman Ross mentions, they can get that close to home, not only to help assist the VA, but also to protect our local hospitals. Any comment you might have that for someone like me that serves in a rural area?
Oh, absolutely. I think of not just with my bill, but anytime a service person wants, a serviceman or woman wants service, and they can get it locally and they can get what they need locally. If they live next door to the VA hospital, if they live in Nashville, instead of going to Vanderbilt, you go to the VA hospital, I might get that because I live just close to Nashville. But if they're, out where you are, they should be able to get the service where they got it. And I have people in my district like that aren't as close to Nashville as I am. I know I'm in Kentucky, but we're on the border. And so I agree with you. I think we ought to find a way to deliver services the best that we can to people in the way that they can receive it.
Yeah, I appreciate that. And the VA had an initiative a few years ago. They're proceeding with that Project Arch, and one of the pilot spots was formerly in my district. But I'll note in the first year they hadn't found a single person that had received mental health services through that pilot project. And so we have a long ways to go. I appreciate your gentlemen's proposals and look forward to working those in the committees. Mr. Chairman, I yield back.
Thank you. I'll now yield to my colleague, Dr. Ruiz.
Thank you very much, Mr. Chairman. Thank you both, Dennis and Brett, for your work in introducing these bills. I applaud and encourage highly the gathering of accurate data. I believe very much in evidence-based medicine, and I believe very much in evidence-based policy. And that's the best way that we can find the bottlenecks that is justified through the information that we get on performance measurements in order to make the best decisions and the best policy that we can for our veterans. Brett, I am a strong supporter of our Euro trauma surgeons and making sure that we provide the best treatment. This is something that we need to follow through all the way to the outcomes and measuring what those outcomes are. I know that Dr. Edney has been the champion and going around meeting a lot of us on the committee, and I applaud his work, and I encourage more urologists to do the same. In terms of the task force, oftentimes there's concerns that the task force or advisory committee recommendations are ignored and are not very effective, and this is something that we can't let happen. So what can we do to ensure that any recommendation is actionable and we can carry through to have some actual outcomes?
Yeah, that's frustrating. Though I say sometimes task forces with good ideas go to die sometimes. And we just have to do the oversight. They have to report 2 years after the task force is implemented. They have 1 year for a report, a second year of the final report. And I think it's our job as members of Congress, as people have brought this issue to us, is that to make sure these are implemented and have oversight of the implementation of the task force, because it'll go as far as we reflect. Hopefully it'll go without us oversight, but certainly our oversight will help it move forward. And I think that's what we have to do, is be dedicated to this issue.
Well, I look forward to working with you on this, and after the recommendations are given.
I appreciate that very much. Really look forward to it.
Well, does anyone else have any questions of the panel? Well, I certainly appreciate your time this morning, gentlemen. Looking forward to working with you on this legislation, and we'll move it forward. Thanks. I'd like to welcome the second panel to the witness table, please. Joining us on the second panel will be Dr. Mark Edney, a member of the Legislative Affairs Committee and the Urotrauma Task Force for the American Urological Association. Mr. Michael O'Rourke, who is the Assistant Director of Government Relations for the Blinded Veterans Association. Mr. Adrian Atizado, the Assistant National Legislative Director for the Disabled American Veterans. And Mr. Alex Nicholson, Legislative Director for the Iraq and Afghan Veterans of America. And Ms. Alethea Prideaux, Associate Director for Health Analysis for the Paralyzed Veterans of America. I hope I got your name right. Thank you for all your service to our nation in uniform and through your advocacy work. I appreciate you all being here today, and look forward to hearing your views. And let's begin the panel with Dr. Edney. Please go ahead. You have 5 minutes.
Ranking Member Brownlee, members of the committee, honored guests, fellow service members, I thank the Committee on Veterans Affairs Subcommittee on Health for inviting me to testify regarding H.R. 984, a bipartisan bill introduced by Representative Guthrie to direct the Secretary of Defense to establish a task force on urotrauma. I'm a urologist, a surgical specialist who treats genitourinary disease and injury. I'm also an Army Reservist of 11 years. My active duty tours include service with the 399th Combat Support Hospital in Mosul, Iraq in 2006. I've treated genitourinary trauma in the theater of operations, and have also participated in its chronic management at our largest military medical center stateside. It's an honor to represent the American Urological Association, the world's premier professional association of urologists, and our Urotrauma Coalition in support of H.R. 984 on behalf of this unique class of injured service members. Our Urotrauma Coalition includes distinguished medical societies, including the American College of Surgeons, the American Congress of Obstetrics and Gynecology, the Society of Women's Health Research, and a diverse group of veteran service organizations and industry partners who all support urotrauma policy initiatives contained in H.R. 984. 50,000 American service men and women have been injured in Iraq and Afghanistan. Recent study indicates that about 1,000 soldiers have sustained injury to the urogenital organs. Approximately 60% of these injuries involve the external organs, including penoscrotal, testicular, and urethral injury, with another 40% involving kidney, ureter, and bladder, and in women, the uterus, vagina, fallopian tubes, and ovaries. Dismounted complex blast injury is the constellation of lower extremity loss, often bilateral, occasionally with upper extremity loss, and often with genitourinary injury. Urotrauma is up 350% in Afghanistan compared to Iraq because of the increased necessity of soldiers to patrol on foot rather than in fortified vehicles. Although veterans suffering genitourinary injury may exhibit no outward evidence, they suffer the life-changing loss of proper urinary, bowel, and sexual function and fertility. These deficits have significant effects on marriages, other social relationships, and enormous effects on overall quality of life. The cumulative physical and psychological impact of Eurotrauma on these soldiers is no less profound than those recovering from extremity loss and neurocognitive injury. As a complex injury pattern, Eurotrauma has not received the same policy attention and care coordination that has been afforded the more common injury patterns such as extremity loss, traumatic brain injury, and eye injury, each with its own center of excellence. Genital urinary injury is increasingly a critical military women's health issue, with women now able to serve in direct combat roles. We must do better with the care and coordination of Eurotrauma. An AUA Eurotrauma work group was convened in 2009 to define areas of opportunity for improvement in Eurotrauma care. To broaden the discussion and establish the framework for accomplishing these policy objectives, the AUA, with Congressman Guthrie, has crafted H.R. 984. This establishes an interagency task force to study a broad range of opportunities for enhancing the prevention, management, and study of Eurotrauma. The task force will evaluate and define improvement opportunities in a variety of areas, including an assessment of the true scope and impact of the injury pattern, the status of prevention, an assessment of current facilities and programs within the DoD and VA engaged in the prevention, management, and study of Eurotrauma, with a special focus on the status of research, expertise, and healthcare infrastructure for female victims of Eurotrauma, and an analysis of the reproductive services available to service members who have been rendered infertile as a result of Eurotrauma. The care of these complicated injuries requires a tremendous amount of expertise and care coordination. It's clear that the transition of soldiers with Eurotrauma from the DoD to the VA represents an area of opportunity, not only with respect to DoD physician to VA physician communication, but also with the geographic placement of soldiers with these unique needs in proximity to the available expertise, technology, and programs in the VA to provide for their needs. Finally, although each of the functional challenges that result from damage to the genitourinary organs is life-altering, perhaps one of the most profound is the loss of fertility. The brave young Americans who are voluntarily putting themselves in harm's way in defense of our country are often doing so prior to their reproductive years. Some are suffering injuries that severely impair or eliminate their natural reproductive capability, shattering a dream of many to begin a family of their own. H.R. 984 seeks an analysis of the technical, administrative, and budgetary mechanisms to allow for enhanced reproductive services for members who have been affected by Eurotrauma or who are at high risk of Eurotrauma. The AUA recognizes that there's much to be done in this area, from pre-deployment sperm banking to cryopreservation of sperm at the initial point of care when testicular loss is inevitable, to providing advanced reproductive services to all military victims of Eurotrauma who are infertile and receiving care in the DoD and the VA. We are currently short of that goal, and the AUA working group also supports legislation to enhance these policies. In summary, the rate of genital urinary injury suffered by American soldiers is up 350% in Afghanistan compared to Iraq as a result of the increased necessity of dismounted patrol. Genital urinary injuries are increasingly common, complex constellation of wounds with devastating long-term implications for urinary, bowel, and sexual function and fertility. These sequelae, in turn, have profound impacts on soldiers' mental health, marriages, and other social relationships, and overall quality of life. H.R. 984 prescribes the comprehensive study required to address the variety of opportunities for improving the prevention, initial management, care coordination, and research of this devastating and increasingly prevalent pattern of injury. We owe these finest Americans no less for the sacrifices they've made for our great nation. On behalf of the American Urological Association and the Eurotrauma Coalition partners, I urge you to support H.R. 984 and favorably report it out of the committee. Again, I want to thank the Veterans Affairs Committee for their invitation to testify before you, and I'm available to answer any questions.
Thank you, Dr. Edney. Appreciate your testimony. Mr. O'Rourke, please proceed.
Thank you, Mr. Chairman. On behalf of the Blind Veterans of America, we thank you for this opportunity to provide testimony on current legislation before the Subcommittee on Health. Chairman Beneček, Ranking Member Brownlee, and members of the House Committee. We are very interested and look at beneficial travel for blinded veterans, H.R. 1284. We appreciate that the Ranking Member Brownlee for introducing the bill. We'd like to point out that last week in the Senate, the VA Committee held a hearing on a companion bill, S-633, introduced by Senator Tester, that was broadly supported by the witnesses. The legislation, H.R. 1284, would assist disabled spinal cord injury and blinded or visually impaired veterans who are currently ineligible for beneficial travel benefits. This bill would assist mostly low income, and catastrophically disabled veterans by removing the travel financial burden to access vital care that will improve independence and quality of life. We look at the blind rehabilitation centers that the VA provides and the spinal cord injury centers, which are probably two of the most renowned facilities the VA has that they utilize. It makes little sense to have developed over the past decades outstanding blind rehabilitation programs known for their very high quality inpatient care, only to tell low-income veterans that they are unable and therefore cannot attend these centers. To put this dilemma in perspective, a large number of our constituents are living at or below the poverty line, while the VA means test threshold for travel is $14,340. This bill here would assist individuals to partake at a blind rehabilitation center. To elaborate on the challenges of the travel for a blinded person, we look at current facts. In a study of new applications for recent vision loss rehabilitative services, 7% had current major depression and 26.9% met the criteria for sub-threshold depression. Vision loss is a leading cause of falls in the elderly. One study found that visual field loss was associated with a 6-fold risk. While only 4.3% of those 65 and older in that population live in nursing homes, the number rises to about 6% for those who are visually impaired and 40% for those who are blind. Medicare direct cost of this is $11 billion per year. If blinded or spinal cord injury veterans are not able to obtain the rehabilitative center training to learn to function at home independently because of travel cost barriers, the alternate charges for nursing home care, assisted home care, are far larger than they can afford. Thus, the federal government usually subsidizes in the form of Medicare. We caution that private agencies for the blind are located in large urban cities, New York City, Chicago, Seattle, Orlando, or Boston. So travel barriers would preclude utilization of many of these sites for some of our veterans. VA centers often use specialized nursing, physical therapy, audiology, pharmacy, radiology, and laboratory support services that are necessary for clinical care and blinded veterans. Again, we stress one of the big challenges is that in the civilian medical world, there is not a high incident of these kinds of facilities that are available to veterans. That concludes my testimony. I will be able to stand by and answer any questions you might so have.
Thank you very much, Mr. O'Rourke. I really appreciate your time. Mr. Adezato, please go ahead for 5 minutes.
Thank you, Chairman Benishek, Ranking Member Brownlee, members of the subcommittee. On behalf of DAV's 1.2 million wartime wounded and injured veterans, I am pleased to present our views on legislative measures subject to today's hearing. Requesting my written testimony be made part of the record, I will only address those bills on today's agenda for which DAV has a mandate from our membership. The Veterans Integrated Mental Health Care Act of 2013 would establish a new authority for VA to use in contracting for mental health services for eligible veterans. DAV national resolutions were passed at our most recent national convention, which calls for program improvement and enhanced resources for VA mental health programs, as well as care coordination when VA purchases care in the community. However, in light of the subcommittee's hearing on September 14, 2012, and as Chairman Miller had mentioned in his opening statement,
we had discussed the VA's patient-centered community care and non-VA care coordination initiatives. These initiatives are to promote coordinated contract healthcare services, including mental health care. The AV believes this bill overlaid on these initiatives, which are ongoing, would hamper VA's efforts and thereby cause disruption and delay to reform all contract and fee-based health care. Mr. Chairman, I would like to note at this point that it's been years since we've been asking for care coordination and contract care, which is why we believe enactment of this bill should be done prudently. For these reasons, the AV recommends that this bill be held in abeyance at this time until we realize, or at least find out in concrete manner, how this bill, if enacted, would impact the current initiatives. H.R. 241, the Veterans Timely Access to Health Care Act, would establish a statutory access to care standard of 30 days within the VA healthcare system. The bill would also require VA to submit to Congress continuing semi-annual performance reports on waiting times. Now, timely access to needed medical care is a critical domain of high-quality care. Our membership approved national resolutions addressing timely access to VA healthcare services for service-disabled veterans. However, we urge the committee again against prescribing a single standard of waiting times across a universe of appointment types, as was mentioned earlier with the first panel. A 30-day standard may lengthen waiting times considering VA's current access standards. DAV believes the transparency potential conveyed in this bill to document more accurate waiting times is a worthwhile concept. We ask for consideration in adding to the reports greater granularity, such as including waiting times for purchase care, care purchases in the community, whether it's mental health or inpatient or rehab services. We also ask for greater specificity in reporting, such as performance reporting by each VA facility. H.R. 288, the CHAMP VA's Children Protection Act of 2013, would extend the maximum age eligibility of a qualifying veteran's child to CHAMP VA coverage from age 23 to 26. Only if the child is pursuing a full-time course of instruction at an approved educational institution or is unable to continue to do so because of a disability not resulting from a child's willful misconduct. Now, DAV supports this measure based on a resolution number 222. However, we strongly urge amending it to conform to Public Laws 111-148 and 111-152. These two public laws require private health insurance to cover adult-dependent children in covered families until these individuals attain the age of 26, irrespective of marital status, financial dependency, or other factors, and including, in this instance, educational status. The AV urges the measure to be amended to ensure children of severely disabled veterans and survivors of veterans who have paid the ultimate sacrifice enjoy the same rights and privileges as other young adults of our country. This concludes my testimony, Mr. Chairman. Thank you for allowing DAV to testify, and I would be pleased to answer any questions you or other members of the subcommittee may have.
Thank you very much for your input, sir. I really appreciate it. Mr. Nicholson, please proceed with your testimony for 5 minutes.
Thank you, Mr. Chairman, Ranking Member Brownlee, and distinguished members of the subcommittee. On behalf of Iraq and Afghanistan Veterans of America, or IAVA, we thoroughly appreciate the opportunity to share our views regarding these important pieces of legislation pending before you today. As many of you know, IAVA is the nation's first and largest nonprofit, nonpartisan organization for the veterans of the wars in Iraq and Afghanistan and their supporters. Founded in 2004, our mission is important but simple: to improve the lives of Iraq and Afghanistan veterans and their families. With a steadily growing base of over 200,000 members and supporters, we strive to create a society that honors and supports veterans of all generations. IAVA believes that all veterans must have access to quality health care and related services. IAVA is therefore supportive of each of the bills that are the subject of this hearing here today. With regard to H.R. 241, IAVA supports the Veterans Timely Access to Health Care Act because it will help hold the VA accountable for meeting maximum allowable wait times. A veteran's ability to access timely care plays a vital role in sustaining his or her quality of life post-service, but from a mental health point of view in particular, the importance of providing timely care becomes even more critical. Timely mental health care can sometimes mean the difference between life and death for veterans in crisis, and IAVA believes that every VA medical center and healthcare provider should be able to provide reasonable standards of timeliness when providing care for veterans. IAVA also supports H.R. 288, the CHAMP VA Children's Protection Act of 2013. With the enactment of the Affordable Care Act, children up to age 26 can now be covered by their parents' health insurance plans. While legislation was subsequently enacted to extend this coverage to eligible children of TRICARE recipients, this legislation is still needed so that benefits can also continue to be similarly provided to children of our nation's wounded warriors under CHAMP VA. IAVA also supports H.R. 984, which would establish a task force on urotrauma in order to expand research on and develop new care recommendations for these injuries. Urotrauma, which is often seen in service members and veterans who have sustained blast injuries, has unfortunately become more prevalent among those who have served in Iraq and Afghanistan. Because of advances in modern treatment practices within the military medical community, service members and veterans are surviving these types of injuries with greater frequency than in past conflicts, which means that VA now finds itself treating more injuries, such as genitourinary injuries, for which there may not be a wide range of experience or vast body of knowledge extant within the system. IAVA sees H.R. 984 as an important step in providing the necessary research and treatment options to address these serious wounds of war. IAVA supports H.R. 1284, which would authorize the VA to reimburse the travel costs associated with seeking approved inpatient care at a VA Special Disabilities Rehabilitation Program for additional categories of catastrophically disabled veterans. We believe this legislation will provide critical assistance for more disabled veterans to allow them to receive the specialized inpatient treatment that they need. IAVA also supports Chairman Miller's draft bill, the Veterans Integrated Mental Health Care Act. IAVA's 2013 member survey revealed that 80% of respondents don't think service members and veterans are getting the mental health care they need. IAVA believes that one way to help address the mental health care needs of veterans is through building the type of community partnerships that are advocated for and facilitated by this bill. And we believe this bill is a step in the right direction toward building such positive and beneficial community partnerships. And finally, IAVA supports the Demanding Accountability for Veterans Act, which would formalize the system of accountability within VA, give the VA Inspector General's report recommendations more authority, and institute consequences for failing to fix problems clearly identified by the VA's IG. IAVA believes this bill will strengthen current systems of accountability by narrowing the focus of scrutiny as to who is responsible for producing and correcting IG-identified public safety issues. Mr. Chairman, we at IAVA again appreciate the opportunity to provide our views on these important pieces of legislation, and we look forward to continuing to work with each of you, your staff, and the subcommittee to improve the lives of veterans and their families. Thank you for your time and attention.
Thank you very much, Mr. Nicholson. I appreciate your comments. Ms. Trudeau, 5 minutes.
Chairman Benishek, Ranking Member Brownlee, and members of the subcommittee. Paralyzed Veterans of America would like to thank you for the opportunity to present our views on healthcare legislation being considered by this subcommittee. These important bills will help ensure that veterans receive the best healthcare services available. We are particularly pleased that two bills, H.R. 288 and H.R. 1284, that are very high priorities for PVA, are being considered today. My remarks will focus only on a few bills, as PVA's full statement has been submitted to the subcommittee. At this time, PVA does not support the Veterans Integrated Mental Health Care Act of 2013, a bill that would require the VA to provide veterans with an integrated delivery model for mental health care through care coordination contracts. The VA is currently working on multiple initiatives to improve care coordination with private providers and increase timely access to mental health services. More specifically, the VA is in the process of transforming its national non-VA care program in an effort to improve coordination services with non-VA providers, which includes mental health services. PVA believes that the current VA initiative should be further developed before additional resources are put into another program for non-VA care coordination. PVA generally supports the intent of the Veterans Timely Access to Health Care Act, which proposes to direct the VA Secretary to establish standards of access to care for veterans seeking services from VA medical facilities. If enacted, this bill would establish a standard for access to care that requires the date on which a veteran contacts the VA seeking an appointment and the date on which a visit with an appropriate health care provider is completed to be 30 days. While this legislation may potentially improve the delivery of VA services, the language does not take into account the fact that the standard for access to care may vary depending on the type of care needed. As such, PVA has concerns regarding the use of a 30-day standard for access to care without specifying the type of care that is being provided. While PVA believes that timely access to quality care is vital to VA's core mission of providing primary care and specialized services to veterans, it is also important that factors such as the nature of the services provided and efficient use of VA staff and resources be considered when developing standards for access to care. PVA supports H.R. 288, legislation to increase the maximum age for children eligible for medical care under the Civilian Health and Medical Program of the Department of Veterans Affairs, CHAMP VA. CHAMP VA is a comprehensive health care program in which the VA shares the cost of covered health care services for eligible beneficiaries, including children up to age 23. As part of health reform, all commercial health insurance coverage increased the age for covered dependents to receive health insurance on their parents' plan from 23 years of age to 26 years of age, in accordance with the provisions of Public Law 111-148, the Patient Protection and Affordable Care Act. This change also included health care coverage provided to service members and their families through TRICARE. Today, the only qualified dependents that are not covered under a parent's health insurance policy up to age 26 are those of 100% service-connected disabled veterans covered under CHAMP VA. This unfortunate oversight has placed a financial burden on these disabled veterans whose children are still dependent upon their parents for medical coverage, particularly if the child has a pre-existing medical condition. PVA believes that this legislation will make the necessary adjustment to help veterans and their families in this position. Lastly, PVA strongly supports H.R. 1284, a bill that, if enacted, would provide coverage under the Beneficiary Travel Program to non-service connected veterans with a spinal cord injury or disorder, double or multiple amputations, or vision impairment. Too often, catastrophically disabled veterans, particularly non-service connected veterans who do not have the benefit of travel reimbursement, choose not to go to VA medical centers for care due to significant costs associated with their travel. When these veterans do not receive the necessary care, the result is often the development of far worse health conditions and higher medical costs for the VA. For veterans who have sustained a catastrophic injury like a spinal cord injury or disorder, timely and appropriate medical care is vital to their overall health and well-being. PVA believes that expanding VA's beneficiary travel benefit to this population of severely disabled veterans will lead to an increasing number of catastrophically disabled veterans receiving quality, timely, comprehensive care and result in long-term cost savings for the VA. Again, thank you for the opportunity to submit PVA's views on the legislation being considered today, and I'm happy to answer any questions that you may have.
Thank you, Ms. Prideaux. I'm going to yield myself a few minutes to ask a few questions of you about some of the legislation. I want to thank you all for your candid comments, because I think your input is very valuable. I mean, I had some of the same thoughts about some of the legislation myself, the questions that you brought up, but I'm so happy to hear your opinion. And I hope that you all be willing to work with the committee to try to improve some of this legislation. I know that many of you had concerns about the Chairman's Veterans Integrated Mental Health Care Act, and I'm concerned about the fact that we addressed the concerns that you brought up, so hopefully that you'll be able to work with the committee and the chairman to address that. I mean, I have a question about concerning my legislation, the Demanding Accountability for Veterans Act. I sponsored this after I had a hearing where they had this IG report where they haven't had a plan for physician staffing of the VA for the last 30 years, and the IG had reported like 8 times that we should do something, and then the VA reported back, well, we're going to have something in 3 years. And I just can't imagine how we could get people to do what they're supposed to do at the VA. And, with the amount of open IG recommendations, do any of you have any other ideas as to how we can make these particular managers more responsible? I mean, I understand that Congress has oversight responsibility, but we come upon an incident somewhere in the VA and we highlighted here in committee, and it's all talked about everywhere. But there's things going on. There's 1,000, open IG recommendations. We can't get to every one of them in these committees for oversight, and the IG is their own oversight. So shouldn't we have those IG reports have some teeth in them? And I'd like to ask any of you if you have any opinions as to, what my legislation does, or if you have a better idea as to how to hold the VA accountable for, getting things done. Mr. O'Rourke, do you have anything?
No, sir, not at the present time.
Mr. Adezago?
Thank you for that question, Chairman Benishek. I can tell you that it's an appropriate question to ask about IG's recommendations. I actually had the opportunity probably about a year and a half ago to try and follow up on these recommended actions, and I couldn't follow it. I called between IG and the program office at VA to see what the status was on the recommendations, and for the most part, the actions that were recommended were actually negotiated, which means the recommended actions that were written on the report were not actually the recommended actions that VA was working on as agreed upon by OIG. Meaning to say, Mr. Benishek, that while this bill intends to put some greater enforcement and accountability on the part of the IG, we have to be a little bit more thoughtful on how this is done. For example, better definition of what covered reports are. Ostensibly, anything that VA does, which is a public health institution, deals with public health and safety. Does it include all the reports that the IG provides? What does significant progress mean? Just some thoughts, Mr. Benishek. That's all I have.
Yeah, well, I understand what you're thinking, but I'm trying to find the best way to do this too. How do we hold the VA accountable? How do we get those people to actually produce? Mr. Nicholson, do you have any other ideas there?
I would just add, Mr. Chairman, that I think we are on the same page in terms of solutions that would actually have teeth to them. I think whether it's public safety issues, IG recommendations, following through on reducing the backlog, it doesn't sort of matter what issue you look at. The VA, I think, keeps promising us progress year after year, and we see backlogs and not only disability claims issues, but like you mentioned earlier in following through on all these outstanding IG recommendations. So something I think that would add some teeth to the accountability factor, I think, would be certainly welcomed by us. We hear from our members consistently year after year. We certainly, we do an annual survey of our membership, which is one of the largest that's done independently of Iraq and Afghanistan era veterans. And we consistently hear that while veterans are satisfied with the care they receive, they continue to be dissatisfied overall with the VA itself. There's sort of a disconnect between sort of the tactical level and the strategic level here. And so, I would say from our perspective, solutions like you mentioned with teeth would certainly be welcome. And I think it's high time that we start adding teeth into these types of bills. Thank you.
I may want to talk a little bit more about this, but I want to give Ms. Brawley an opportunity to ask some questions.
Thank you, Mr. Chair. This is, again, I also want to thank everybody here who has testified and appreciate your comments and recommendations. And I want to particularly thank Mr. O'Rourke for a detailed perspective on H.R. 1284 and the benefits for veterans. I'd like to, hear from the Blinded Veterans Association and the DAV and the PVA if they have any comments relative to some of the VA testimony that this particular bill, as written, might provide some desperate travel eligibility to a limited group of veterans, and they would favor opening up the travel benefits to a wider group of veterans, of course, contingent upon funding, but would like to hear your response to that suggestion.
I can begin. PVA certainly wouldn't be opposed to expanding that benefit. However, we believe that the 3 populations that are targeted is a good start, simply because these groups have systems or centers of care within the VA that are not always geographically accessible for this population of veterans, these populations of veterans. When you consider that they may have clinics or other access to VA facilities, comprehensive care that is needed at least at a minimum, oftentimes more, once a year, getting to those facilities oftentimes could 3 to 4 hours. And so to ensure that they're receiving the care at least once a year, we wanted to make sure that cost did not prevent them from doing that. So it's those centers of care, oftentimes we can't have one everywhere, and particularly in the rural areas. So I think that this is a good first steps, and we would definitely support the expansion of the benefit to other veteran populations.
Thank you. Mr. Adesato?
Ranking Member Brownlee, thank you for that question. So in our testimony, we talk about possibly expanding beyond the current statutory requirement, as well as what this bill proposes to do, simply because there is a provision, actually it's paragraph 2, below the one that this bill wants to amend, that gives the Secretary discretionary authority to provide these benefits to any other veteran that the Secretary deems fit or appropriate, to which we don't believe it's actually been exercised, but for very anecdotal, very specific instances. For example, in facility transfers from SEI to SEI, air travel, things of that nature. So the need is there, and there's a wide gap between those anecdotal incidences as well as these 3 population. We think it should be a little bit more broader with the sense that it should be there should be more parity. Yes, the 3 population that this bill considers is certainly deserving, but there are others as well, whether it be those who are frail elderly who just can't drive and need somebody to help them drive to a facility, things of that nature. That is where we would like to see this provision grow. We agree with PVA it is a good first step and wouldn't oppose its enactment.
Thank you for that. Mr. O'Rourke, do you have any additional comments?
Yes, ma'am. I think the VA has some outstanding facilities, and I think that at times they go underutilized. So my point being here is we'd like to expand into the inpatient treatment facilities more patient care from eligible veterans. And this would be the first step for those that are non-service that come down with age-related disease entities. As we progress in age, some things just happen to us. We don't want them to happen, but they do. Glaucoma becomes more constant. Diabetic neuropathy with the diabetic population and our veterans. We look at macular degeneration. We look at the many different types of wounded that are coming back from OIF, OEF, that IED, that blast, does not just stop at the TBI or the traumatic brain injury. It affects the eyes, it affects audiology, it affects the lower abdomen. I wish we had Kevlar to take care of that, but we do have fine upstanding VA facilities that I think are going underutilized, if that's appropriate terminology. And I think we have the veterans that need and deserve the care at these facilities. And this travel bill will assist them. And they do such good work there that I would think that it would be advantageous for the VA to do it in many other arenas. But I understand finances, And at today's society, I think it's the next right move.
Thank you very much, and I'll yield back to the chairman.
Thank you, Ms. Brownlee. Well, we have a few more questions, but I think maybe I will submit some of the questions that I have to you in writing and hopefully get a response from you there, because I know as far as my legislation is concerned, I don't want to have any, loose areas, let me put it that way, that, I want to have some strict definitions of what's going on there so that we can actually hold people accountable and not slip out, if you understand what I mean. So I truly appreciate all your comments here today and look forward to speaking to you further about these issues and these pieces of legislation. I truly appreciate your time in being here today. So unless you have any other questions, you can expect a few written questions from us, and the panel is now excused. Thank you very much for being here. And at that point, then, we're going to welcome our third and final panel to the witness table, and that will be from the Department of Veteran Affairs, Dr. Robert Jesse, the Principal Deputy Undersecretary for Health. Dr. Jesse is accompanied by Susan Blowart, the Deputy Assistant General Counsel. So, Dr. Jesse, thanks for joining us today. Appreciate your presence, and I look forward to your comments about the proposed legislation before us, and you can proceed when you're ready.
Well, thank you, sir, and good morning, Chairman Benishek and Ranking Member Brownlee, and members of the subcommittee, and thanks for the opportunity to address the bills on today's agenda and the impact that these are going to have on the VA. And as you mentioned, I'm accompanied by Susan Blowart, VA's Deputy Assistant General Counsel. So we very much appreciate your continued efforts and those of the subcommittee to support and improve veterans' health care. Because of the short timeline for preparation views, we don't have a formal testimony on two of the draft bills, H.R. 241, the Veterans Integrated Mental Health Care Act of 2013, and H.R. 94, Demanding Accountability for Veterans Act of 2013. Despite not having formal prepared views on these bills, we do recognize the importance of addressing these underlying issues and that are related in each of these bills. In fact, all these bills are issues that are very important to the VA. For example, we've worked steadily to implement the letter intent of the executive order improving access to mental health care services for veterans, service members, and military families. We believe that we've made significant progress towards hiring mental health professionals, and many of the other ongoing mental health initiatives demonstrate our strong commitment to ensuring the availability of mental health services to all of our veterans wherever and whenever it's needed. Likewise, VA understands the needs for system and organizational processes that support a culture of excellence and one of accountability. And H.R. 241 and your draft Demanding Accountability for Veterans Act both seek to hold VA to high standards. And please know that we share those common values. And I will take a moment and explain now the position we have on the two bills for which you were able to complete views. There's a more detailed treatment of these in my written statement. VA generally supports bills that expand services to veterans when resources permit us to do so, and this would include increasing the maximum age to 26 for eligibility of young adults covered by our CHAMP VA program. We're concerned with the bill as it's written because we fear it may not accomplish the objective because it fails to address a technical definition of the term child contained in the current statute, and our written statement provides a more detailed explanation. I use the term young adults because I have kids that age and they don't like it when I call them children. Be assured that we're anxious to work with the committee toward providing the best language to support the intent of the bill. We fully support ensuring that CHAMP VA coverage is consistent with private sector coverage provided under the Affordable Care Act. The second bill, H.R. 1284, would extend VA's beneficiary travel benefits to certain veterans with vision impairment, spinal cord injury or disorder, and double or multiple amputations. The eligibility provided on this bill is offered specifically for when this class of veterans is traveling to receive care from a VA special disabilities rehabilitation program on an inpatient basis, or when the trip qualifies for temporary lodging. And I've been well schooled by Tom Zimpari and Mr. O'Rourke about the complexities of getting particularly blinded veterans back and forth, even for their primary care appointments. We believe the legislation could be improved then by broadening the scope. VA supports extending the beneficiary travel eligibility to all veterans who would be who could most benefit from the program. VA provides rehabilitation for many injuries and diseases, including for veterans who are catastrophically disabled. VA also provides care at numerous specialized centers other than those noted in H.R. 1284. For example, we have other programs for closed and traumatic brain injury, for post-traumatic stress disorder, military sexual trauma, and other various addiction programs. Many of these programs provide outpatient care to veterans who might not require lodging but still travel significant distance or are challenged in traveling to those appointments on a daily basis. And under this proposed legislation, the group of veterans would not be eligible. For these reasons, VA doesn't support the legislation as written because it would provide disparate travel eligibility to a limited group of veterans. However, we do support the idea of travel for a larger group of catastrophically disabled veterans, including veterans who are blind or have SCI and amputees, and those with special needs who may not otherwise be eligible for travel benefits. Once again, VA welcomes the opportunity to work with the committee to craft appropriate language that is mindful of both resources and especially the needs of these veterans. So thank you for the opportunity to testify before the committee, and we'll be pleased to answer your questions.
Well, thank you very much, Doctor. Let me ask you a question. How much time did you have then to prepare for the hearing today? When was the notice given? Because you said you didn't respond because there wasn't enough time.
Well, I would defer that to our congressional affairs people because I'm not aware exactly when it came in, but I think it was in less than 2 weeks. So it was a relatively short notice.
All right. Well,
we can get the exact timing for you.
Well, I'm just curious. I think 3 weeks is probably the standard, I guess, for the hearing notice. And I just feel disappointed when I hear that answer. In view of email and that nowadays is usually happens pretty quickly. So it seems like 2 weeks would be a pretty good amount of time to figure out a response to some of this legislative ideas. You understand the purpose of my piece of legislation, Dr. Jesse.
Yes.
I mean, I'm trying to figure out how to get the VA to get some things done that don't seem to be getting done. And some of the comments by the previous panel maybe identified some shortcomings. They don't specifically enough target what exactly I'm looking for in there, so that, because I just don't like the fact that people be a manager of a project that don't respond to an IG report for over a year, and this incident of the no physician plan for staffing has been going on for 30 years with 8 separate IG reports over the past 30 years. And then when I had them in front of my committee, a month ago before that hearing, it was said, well, they're going to have a plan in 3 years. And they have agreed that they need a plan for the last 30 years, and yet nothing is getting done. So how do I fix that, Dr. Jesse?
So I guess reflect on that in my experience within the VA. My job prior to this one was as the director of, initially as cardiology and then of medical surgical services. And I know that there's been work on this. In fact, I'm not sure about the exact date, but it was about the time that I became head of medical surgical services. An office was stood up, the Office of Productivity Evaluation, really looking exactly at this. And it's up in Boston, and we found that primary care is pretty easy. You can build a panel, and we work on the goal of about 1,200 patients per primary care provider. And but for specialty care, it's quite a bit harder.
Well, no, I understand all that for that particular issue. Okay, and it's not so much the physicians. I mean, I mean, the private sector does this kind of stuff all the time. So, well, the fact that, I mean, that's just one of the issues that I'm getting at. Okay, I mean,
Okay, yeah.
I mean, I understand that as a physician, you kind of figure this out. You know what I mean? But what I'm worrying about is not the, you know, there's some manager somewhere whose responsibility was to get this done. It seems like something could have been done in the last 30 years with 8 reports and, you know, the VA agreeing with the reports, but nothing happening. And you know, I think that identifying the person in charge of that program is important, because when we have these people before us, it's never the actual person that was in charge that actually appears here. And then we have a hard time figuring out who that person actually was. You understand what I'm saying?
Yes. I think, I guess my comment to that would be, often it's not a person that gets responsible for, so it may not fall under one particular program office at times.
Yeah, that's
and that's part of the problem is I mean, you're exactly correct in how one assigns the lines of accountability to get things done. These are often, well, everything's complex in healthcare.
Well, I know, but I mean, I hate when you come up here and you say to me, there is no one who's responsible. You see what I'm saying? You kind of said that there.
Well,
there's no one person responsible. So then how do we hold it? Because everybody else, you know, they shift that responsibility here and there. It wasn't my fault. That's not my department. It's the other. You know what I mean? We need to have that better defined, and I'm trying to fix that. And my legislation is an attempt to do that. You know, it may not be perfect. That's why I want input.
No, and I think you're exactly correct in looking at these issues that are open for long periods of time and don't meet their deadlines, because clearly there's something wrong. If we've committed to do something in a certain amount of time and we're not getting there, then we owe an explanation as to why. And sometimes there are very good explanations, but often there are not. And I think when we don't, then we do need to be held accountable for them, and to you, and with the transparency that we believe we operate under, to make that clear.
Yeah, well, I appreciate your comment and the fact that sometimes there isn't anyone responsible. That's a really good point that you make there. And I think maybe we can try to fix that as we look at, you know, adjusting this bill and actually have it have some teeth. So I appreciate that. Allow Ms. Brownlee an opportunity to ask questions.
Thank you, Mr. Chair. And I wanted to follow up as well on the bill that I'm carrying, and H.R. 1284, and I certainly appreciate your testimony with regards of expanding these kinds of services to a larger population. I'm just wondering if you have any kind of cost estimate if it were expanded?
I don't have it in my head, but we could certainly get that to you.
So you've looked at it then?
Yeah, I think we've looked at it. I can probably look it up in here, but we can get a rough estimate to you. But I'd like to answer that from a different side, and because it's an important issue and it's not quite as quantitatable. But we know that one of the most costly things in medicine is when people miss appointments, and that in general, making sure that patients get to appointments is in a very broad scope cost effective. And that's not just related to the cost of the travel, it's the cost of the complications of untreated diseases, it's the cost of compliance and all these other things that add in. And this has been a pretty consistent theme that we've seen, but also in a lot of the other large health systems. And so it's one of the reasons why we're, you know, regardless of the cost, we're very supportive of the ability to get patients to their appointments. It's also one of the reasons why we're so strongly committed to really moving healthcare from being about just the appointment to being about these sustained relationships. Because so many of these issues can be mitigated if patients can just reach into the system. And through telehealth, secure messaging, and any other number, you've all heard a lot about where we're going in those directions. These are important contributors to ensuring good healthcare, but they're all part of a large package. But that's one of the reasons why we're so strongly committed to that, so everybody doesn't have to come in from an appointment. But when they do, we want them there. And that's why we're very supportive of the transportation. And particularly rural transportation. And I know that Mr. Michaud is very committed to this.
Well, just, following up with that, and I appreciate your comments relative to that. So, because I think everybody here really does believe that a bill like this, providing the transportation, making sure that veterans show up for their appointments and so forth, in the long term is a cost savings, will be a cost savings to the VA. And really a bill like this, I wish it was always presented as a cost savings as opposed to a cost. And just wondering, again, whether the VA has done any kind of analysis to demonstrate and quantify, if you will, what the real savings are.
I can get back to you on the record for that. I just can't tell you right now.
So you actually have all of that information?
Well, I'll see what we do have. I know this is an area that we've been very interested in. I know we've got a lot of interest in looking at this. I just can't tell you precisely the numbers and data that we have at this time. But okay. We'll get back to you with where we are on that. Okay, great. And I just wanted to follow up on my colleague's bill, Mr. Michaud's bill, and the CHAMP VA, and appreciate your comments vis-a-vis the technical area and the bill, and certainly will appreciate your technical assistance so that we can, get the bill. We believe this is important. We just want to make sure it's correct.
Okay, great. Very, very good. And the other thing is that I understand that in terms of the identifying the population, the young adults, as you referred to, there were some statistics from the March 31st in 2010. There was some data on that. I'm just wondering if there's any updated data on that. I think that the 2010 data run said that the VA estimated a figure of about 59,000 additional young adults that would become CHAMP VA eligible. And just wondering if you have any updates on that.
I think it's going to be in about that same range.
Okay.
We do know those numbers.
Thank you, sir. I yield back my time.
Well, I have a couple of little follow-up questions.
Sure.
I think we're going to end up submitting some written questions to you as well, Dr. Custy, and I appreciate your written response to them later. But one of the comments that Dr. Edney made, the urologist that testified, yes. Talked about the difficulty sometimes coordinating urotrauma care in the VA when the veteran ends up going to a VA close to his home. Do you agree that coordinated, sort of centralized effort to treat a long-term urotrauma would be a good idea, and how do you see that working within the VA system?
So I was very interested in this testimony, and a couple things sort of came to my mind. One is, as he mentioned, the complexity of moving patients from their active duty into the VA system, and it argues very strongly for the work that we're trying to get through with the VEAL, or the Virtual Lifetime Electronic Record, to make sure that moves across. VA we already has, I think it's about 16 of our VISNs have centers that can deal with complex urinary trauma, including the 5 polytrauma centers. And these are the kind of specialty care that need to go to specialty places. This is the type of thing that I would normally be thinking about, and my thinking on this was changed pretty dramatically about a year ago. I was sitting on a plane, and the woman in the middle seat next to me was quite upset, and it turned out she was upset because her husband was at the front of the plane and she was at the back of the plane, and the guy sitting up front wasn't willing to change seats with her. But I got to talking to her. Her husband had complex GU trauma. And I learned an awful lot about, he was getting excellent care for this, but the issue was far beyond the technical surgical care. There were just so many complex family issues involved in this. And that's not the stuff that moves to the specialty centers. Yes, we have expertise in there, but that kind of care needs to go on everywhere when they get back into their communities, and it needs to be very much a part of all the rest of the health care that they get. And that's the coordination piece that I think you talk about. We need to make sure that our providers are attuned to these issues and can deal with them in more than the technical, medical, and surgical parts, but also be very attuned to the the complexities that go along with these. So we've done a lot in educating, particularly about military sexual trauma. The Women's Health Program at VA is just astounding in the work they've done in the past 4 or 5 years, and particularly now with work in reproductive health, which was part of his testimony. So all these pieces are in fact coming together. But if it's just about the technical GU surgery piece, I think the specialized centers are really important. But I think we also need to have the windows wide open to see the entire complexity of the situation.
Well, I agree with you that, but I think that the urology specialists provide simply more than just simply the technical expertise. They provide also a value in understanding some of these social issues sometimes.
Oh, absolutely.
Psychosocial issues associated with this trauma, sometimes more than the person at the local VA and who's taking care of the patient. So I agree that the person at the local VA should be in communication with the specialist so they have a familiarity with those things. But as a general surgeon, I feel a little bit distraught when you say it's simply a technical.
So no, I didn't mean to imply that.
We have a more than simply a technical ability. We deal with these issues. Let me ask another question, if you don't mind. In your written testimony, you stated the VA believes that eligibility for coverage of children under the CHAMP VA would be consistent with certain private sector coverage under the Affordable Care Act. Yet during the consideration of and the passage of the Affordable Care Act, the administration did not include in its budget or submit a legislative request to amend the CHAMP VA to extend the coverage for children up to age 26. You know why that happened?
I don't, but we can get that back to you. We were in favor of it. I don't know why it didn't come through from us.
All right. Ms. Brownlee, do you have any other questions? Well, I think that will conclude the hearing today. Please be ready to get the remainder of the questions that we want to have answered to help us formulate this legislation a little better. But I truly appreciate everyone being here and your comments today, and feel free to follow up with the subcommittee for any other input you want to provide. And thank you so much for your time this morning.
Thank you, sir.